Imagine for a second sitting in a cold exam room. You're holding a medical report that has just absolutely terrified you, only to find out that the intimidating, ancient-sounding word printed on the page literally translates to nothing more than a bump.
Yeah, it creates so much unnecessary panic for people.
Right. Today, we are decoding the secret language of modern healthcare. Because, let's face it, if you don't speak this language, a medical diagnosis can feel like this insurmountable barrier. I mean, the vocabulary itself just feels designed to keep you out of the loop regarding your own body.
It really does. Medical terminology is, it's built on these deep layers of Latin and Greek that have evolved and honestly sometimes completely devolved over centuries.
Yeah.
So when you are looking at a diagnostic report, especially in the realm of cancer, you are essentially looking at an archaeological dig of medical history.
Okay, well, let's unpack this, because for today's deep dive, our mission is to hand you the decoder ring. We have a truly fascinating stack of sources for this one. We're looking at historical texts, etymology breakdowns, and some, honestly, wild medical history case studies.
Very wild.
Yeah, we are going to decode 3 specific word parts today: onco, radio, and oma. Because when you put these 3 pieces together, they cover almost everything you hear in a modern cancer diagnosis.
They really map out the entire landscape. You have the naming convention for the physical mass itself, which usually ends in oma.
Right.
You have the overarching field that categorizes and treats the disease, which is oncology, pulling from the root onco. And then you have the invisible technology used to both find and destroy it, radiology, which is built on the root radio.
I want to start with the ending of the word, actually, because that seems to be the source of the most immediate dread for patients. Before we can talk about chemical cures or radiation, we have to talk about the physical thing a doctor is looking at.
Right, the suffix oma. So it comes from ancient Greek, and originally it simply meant tumor or mass or even just a swelling.
Okay.
In medical terminology, it's the ending that turns a root word into the name of an abnormal growth. But the biggest misconception we need to clear up right away is that oma does not inherently mean cancer.
Wait, really? Because I feel like that is a universal assumption. If someone says, oh, they found an oma, the immediate reaction is to prepare for the worst.
Oh, absolutely. It's a very understandable fear based on how we use language casually today. But historically, when this suffix was standardized in 19th century medical Latin, it was meant to be completely etymologically neutral.
Neutral.
Yeah.
Yeah.
It was just a structural descriptor. It literally just means a mass is occupying space.
So let me see if I have this right. The suffix oma is essentially just the noun building. It just tells you a structure is there. But the root word, acting as the prefix, is what tells you whether you're dealing with like a cozy cottage or a radioactive power plant.
I love that analogy. That is a much better way to conceptualize it than simply defaulting to panic.
Let's look at the mechanics of benign versus malignant growths to see how that holds up.
Okay, let's do it.
Think of a benign oma as a balloon inflating inside a cardboard box. It gets bigger, it takes up space, and it might even push uncomfortably against the sides of the box.
But it stays contained.
Exactly. It stays inside its rubber skin. It doesn't actually invade the cardboard itself.
So it might be annoying, but it respects boundaries.
Precisely. Take a lipoma, for instance. The root lipo means fat, so it's just a fatty lump. It will inflate like that balloon, but it won't kill you.
Right. Okay.
Now, a malignant oma is very different. Think of a tree growing right next to a house. As it grows, the roots don't just push against the foundation. They secrete enzymes, they break the concrete apart, and they actively invade the surrounding structure.
Oh, wow.
Yeah, that is what a carcinoma does. Carcinoma refers to a malignant growth of epithelial tissue, the tissue that lines your organs and your skin.
So the root encodes all the danger. The root is the entire verdict. I mean, sarco means flesh or connective tissue. So a sarcoma is an invasive root-spreading tumor of the bone or muscle. Melano means black or pigment, which gives us melanoma.
But a massive portion of the dictionary is just those harmless balloon-like growths, right?
Oh, a huge portion. Adenoma is a benign glandular growth. Fibroma is a benign fibrous growth. In fact, modern pathologists often prefer the term neoplasm, which just means new growth, because oma has become too ambiguous for patients.
And the ambiguity gets even crazier when you look at the false friends in our sources.
Yes.
These are words that end in the letters O, M, A,
Yeah.
but have absolutely nothing to do with physical masses at all.
Right, the etymological traps. Coma is a great example. It derives from the Greek word coma, which simply means deep sleep. It shares the spelling by sheer coincidence.
And then there is glaucoma. I always assumed that was an eye tumor.
So many people do. But glaucoma comes from the Greek word glaucos, meaning gray or blue. It refers to the clouded appearance of the pupil in advanced stages of the condition.
So there's no mass at all.
None. The disease itself is a mechanical issue of fluid pressure building up and damaging the optic nerve. There is no tumor, just a linguistic coincidence that scares people unnecessarily.
Okay, so if the suffix oma only means there is a lump, where does the actual scary vocabulary come from? I mean, Hippocrates was looking at these growths thousands of years ago. How did ancient doctors separate the balloons from the invasive tree roots?
Well, Hippocratic texts from the 5th and 4th centuries BCE used the Greek root onkos, which gives us the onco in oncology.
Right.
But back then, onkos simply meant bulk or mass or burden. Hippocrates used it very loosely for any swelling, even things we would now recognize as just simple infections.
So where does the word cancer enter the chat?
Hippocrates recognized that some of these onkos masses behave differently. The ones that were hard, invasive, and just refused to heal, he reportedly called those carcinos, which is the Greek word for crab.
Because of the swollen blood vessels radiating out from the central tumor? Like, they look like the legs of a crab digging into the flesh?
Yes, exactly. And when those Greek texts were later translated into Latin, carcinos became cancer. So onkos named the broad category of abnormal burdens, while cancer described the malicious behavior.
Wow. And that brings us to the modern specialty of oncology. Its entire purpose is to evaluate an onkos and determine if it is behaving like a crab.
That's it, exactly.
You would think, though, with roots going back to ancient Greece, that oncology as a distinct medical specialty has been around forever. But according to our historical sources, the job title oncologist is incredibly recent.
It is surprisingly recent. The term itself floats around in the 19th century, sure, but clinical oncology as a discipline didn't truly solidify until after World War II.
Which is wild to think about.
It is. Before that, you had surgeons trying to cut tumors out, and you had early radiologists trying to burn them. But the idea of treating cancer with systemic medicine like chemotherapy was essentially pioneered in 1947.
The story of Sidney Farber at Boston Children's Hospital. He was looking at acute lymphoblastic leukemia in children, right? At the time, if a kid got this diagnosis, there was no hope. It was just a death sentence.
It was considered entirely untreatable. But Farber, who was a pathologist, decided to try a completely novel chemical approach. He used a drug called aminopterin.
How did that actually work? Because the concept of chemotherapy kind of seems like black magic if you don't understand the mechanism.
It really does. To understand the drug, you have to understand the cancer cell itself. Cancer cells are essentially microscopic factories running 24 hours a day, furiously copying their DNA so they can divide and multiply.
Okay.
And to build that DNA, the factory needs raw materials. One of the most crucial raw materials is folic acid, or folate.
So if you cut off the supply chain.
The factory shuts down. Aminopterin is a folic acid antagonist. It chemically blocks the cells from using folate. Farber administered this to a young patient named Robert Sandler, and by starving those rapidly dividing leukemia cells of their raw materials, he successfully induced a temporary remission.
That is amazing.
It proved that chemical compounds circulating in the blood could selectively target cancer.
It's just staggering to look at the timeline here. Farber proves this in the late 40s, but the American Society of Clinical Oncology, ASCO, wasn't founded until 1964. That means the formalized job title of medical oncologist is barely older than the Apollo moon landings.
Yeah, they had to invent an entirely new discipline from scratch, just learning how to walk that razor's edge of poisoning the disease without poisoning the patient. So medical oncologists handle the chemical weapons, like Farber's folate antagonists. Surgical oncologists handle the physical removal, and then you have the radiation oncologists who use energy.
Let's transition to that energy, actually, because this brings us to our third word part. Radio. We've talked about naming the mass and poisoning the mass. How did doctors discover a weapon they couldn't even see?
Well, the root radio comes from the Latin word radius, meaning ray or spoke of a wheel. It describes anything that emits outward from a central point. And the leap into medicine happens in November of 1895 with Wilhelm Conrad Röntgen.
He was a physicist in Germany playing around with cathode ray tubes, right? He notices a fluorescent screen glowing across the room, realizes he stumbled onto a new kind of invisible ray, and calls them X-rays because they're a mathematical unknown.
Right, he had no idea what they were. But he quickly realized they could pass through human tissue, but not bone. He publishes his findings, and what is truly astonishing is the speed at which this theoretical physics discovery was weaponized for medicine.
Oh, it's crazy.
By January of 1896, barely 2 months after Röntgen's discovery, a medical student in Chicago named Emil Grubb takes an X-ray tube and uses it to irradiate a patient's recurrent breast cancer.
2 months. I mean, today, it takes a decade of clinical trials to get a new Band-Aid approved. A medical student just pointed a radioactive tube at a patient and turned it on.
It was the absolute Wild West. And shortly after that, you have Henri Becquerel identifying natural radioactivity in uranium, and Marie Curie isolating polonium and radium. Curie actually coined the term radioactivity.
But they were wielding these rays way before they understood the underlying biology of what the rays were actually doing to the human body. So how does shining an invisible light into someone's chest actually destroy a tumor?
It all comes down to ionization. When we talk about radio in cancer treatment, we are talking about high-energy ionizing radiation. These invisible rays pack so much energy that when they pass through a cell, they literally strip electrons off the atoms inside that cell.
They act like microscopic wrecking balls.
Exactly. And when that wrecking ball hits the DNA ladder inside a cancer cell, it physically snaps the rungs. The DNA shatters. Now, remember how we said cancer cells are factories obsessed with dividing?
Right.
When a cell with shattered DNA tries to divide, its internal machinery catastrophically fails. It triggers a process called apoptosis. The cell essentially commits suicide.
So if you focus a high dose of this energy directly on a tumor, you scramble its blueprint so badly that it kills itself.
Yes.
But there is a massive central irony to this root word, isn't there?
Perhaps the darkest irony in medicine. High targeted doses of ionizing radiation destroy DNA to kill cancer. But low, chronic, accidental doses of that exact same radiation cause minor DNA damage. Just enough to mutate the blueprints without killing the cell.
Oh, man.
And that mutated cell can then become a brand new cancer. The cure and the cause are the exact same mechanism, separated only by dose.
And the historical sources we reviewed have some haunting evidence of this. The Radium Girls in the 1910s and 20s, these were young women hired to paint watch dials with new glowing radium paint so the soldiers could see their watches in the dark trenches of World War I.
Right. And to get a fine point on their paintbrushes, the factory managers instructed the women to use their lips. The technique was literally lip, dip, paint. Day after day, they were swallowing trace amounts of radium.
Why is ingesting radium so specifically destructive? Like, why doesn't the body just pass it through the digestive system?
Because the periodic table is full of cruel tricks. Chemically, radium is almost identical to calcium, and the human body cannot tell the difference. So when these women swallowed radium, their bodies eagerly absorbed it, thinking it was building material, and deposited it directly into their bones.
They were essentially building their skeletons out of radioactive material.
Yes, they were. The radium sat inside their bones, continuously firing off those microscopic wrecking balls. It snapped the DNA in their bone cells over and over, leading to severe jaw necrosis, they called it radium jaw, and massive bone tumors, specifically osteosarcoma.
Which takes us right back to that sarco root we talked about, bone-invading tree roots.
Exactly.
The lawsuits those women filed eventually established modern occupational safety laws, which is incredible. But it wasn't just factory workers. The pioneers themselves fell victim to the dose. Marie Curie died in 1934 of aplastic anemia. Her bone marrow was completely destroyed by decades of handling radioactive materials without shielding.
The discoverer of the invisible fire was consumed by it. It solidified the core lesson of modern oncology. Every tool we have is a double-edged sword.
Which brings us to a fascinating tension in medicine. When you're wielding chemical weapons, invisible ionizing rays, and surgical scalpels, doctors are forced to constantly argue over how much treatment is the right amount. Do you go to war or do you hold back?
Well, for a very long time, the dominant medical dogma was absolute scorched earth aggression. In the 1890s, a surgeon named William Halsted pioneered the radical mastectomy for breast cancer. He removed the breast, the underlying chest muscle, and all the nearby lymph nodes in the armpit.
The underlying logic being that a carcinoma spreads like an ink spill, right? It drips outward in an orderly circle. So if you just carve out a wide enough perimeter, you cure the patient.
That was the theory of contiguous spread, and it dictated surgical practice for nearly 80 years. Women underwent incredibly disfiguring surgeries because doctors truly believed anything less was a death sentence.
And then that changed.
It took randomized clinical trials in the 1970s and 80s, led by a surgeon named Bernard Fisher, to prove that Halsted was wrong.
Fisher proved that cancer doesn't always act like an ink spill. It's systemic.
Yes. Fisher demonstrated that doing less invasive surgery, like a lumpectomy, to just remove the oma itself, combined with targeted radiation, produced the exact same survival outcomes as those radical surgeries.
And sometimes the medical establishment rejects an idea entirely, only to find out decades later it was brilliant, like William Coley.
Oh, Coley's toxins. In the 1890s, Coley was a surgeon who noticed a bizarre phenomenon. Some of his cancer patients developed severe bacterial infections after their surgeries. But instead of dying from the infection, their tumors began to shrink and disappear.
So he decides to deliberately inject a concoction of killed, highly toxic bacteria directly into his patients, which sounds like absolute malpractice.
To his peers, it sounded like madness. But consider the biological mechanism. Cancers are very good at cloaking themselves. The body's immune system often doesn't recognize a tumor as an enemy, it just thinks it's normal tissue.
So the tumor acts like a stealth bomber.
Exactly. But when Coley injected toxic bacteria, it acted like a blaring fire alarm. The immune system woke up, flooded the area with defensive cells to fight the bacteria, and in the ensuing crossfire, the immune cells bumped into the stealth bomber.
They stripped away its cloak and destroyed the tumor.
Exactly. But the establishment threw it out because radiation and chemo were the shiny new toys. It wasn't until decades later that we realized Coley had accidentally invented immunotherapy, harnessing the body's own immune system to fight the cancer.
And that concept won the Nobel Prize in 2018.
It is a humbling reminder that medical consensus is always a work in progress.
Okay, but let me push back on this idea of doing less, especially today. With MRIs, full-body scans, and high-def ultrasounds, we can see inside the body like never before. If I have a tumor in oma of any kind, I don't care if it's a balloon or tree roots, I want it gone yesterday. How can a doctor ethically look at a mass on a screen and say, let's just leave it in there?
It feels completely counterintuitive to the patient. But this brings us to one of the most fierce debates in modern medicine, the crisis of overdiagnosis. And the ultimate case study is what happened in South Korea regarding thyroid cancer.
Walk me through that, because catching cancer early is always billed as the ultimate lifesaver.
South Korea initiated a massive nationwide health screening program that included cheap, widespread ultrasound imaging of the thyroid gland. As millions of people got scanned, doctors suddenly spotted thousands and thousands of tiny nodules, papillary thyroid carcinomas.
So they caught a massive wave of cancer early. They found the omas before they could spread.
They found them, and they aggressively treated them. Thousands of people had their thyroid glands surgically removed and were put on lifelong synthetic hormones. Some suffered vocal cord paralysis from the surgery, but here is the critical data point. Despite finding and cutting out all these cancers, the death rate for thyroid cancer in South Korea did not drop at all.
Wait, if they cut out thousands of malignant tumors, how did the mortality rate not plummet?
Because of a concept called biological indolence. We are conditioned to think of all cancer as a rapidly spreading fire. But some cancers are more like a turtle. They are technically malignant under a microscope, but they grow so incredibly slowly that they will never spread, never cause symptoms, and never threaten the patient's life.
You're saying these people would have died of old age completely unaware they even had a tumor?
Yes, the highly sensitive ultrasound machines were finding the turtles. But because the pathology report used the scary root words papillary carcinoma, the medical system reacted as if it had found a raging fire.
Wow.
The patients suffered the severe physical and psychological harms of the treatment for a disease that functionally was never going to hurt them.
It proves that finding an oma isn't automatically a victory. The technology is so good now that it's forcing us to redefine what actually requires medical warfare. So what does this all mean for you listening right now? We aren't just reciting medical history. This is fundamental health literacy.
When you understand the architecture of these words, you reclaim a bit of power over your own health. You realize that a suffix just means a mass is present, and the root word is where you should focus your attention.
If you see invasive ductal carcinoma on a chart, you can break it down. The oma means there's a mass. Carcino means it's an epithelial growth acting like tree roots. You know you need an oncologist to help manage the chemical weapons, and maybe a radiation oncologist to manage the energy weapons. And this vocabulary applies everywhere, not just the clinic.
It really does.
If you're reading about the Fukushima nuclear accident or debating whether a full-body boutique MRI is worth the money, it all hinges on your understanding of these roots.
It equips you to ask your doctor better questions. Instead of panicking at a word, you can ask, is this mass indolent? Are we dealing with a balloon or tree roots?
It demystifies the language of fear. But before we wrap up, I want to leave you with one final, slightly mind-bending thought to chew on regarding how sticky this vocabulary really is. As we learn today, the radio route is historically tied to ionizing radiation, those invisible wrecking balls that snap DNA.
Right.
But if you walk into a radiology department today for an MRI, the machine uses powerful magnetic fields and radiofrequency pulses. There's absolutely zero ionizing radiation involved.
The terminology has completely calcified, even as the physics have fundamentally changed.
So as you go about your week, navigating the headlines in the hospitals, I want you to ponder this. If a medical specialty named after rays now uses magnets, what other scientific labels in our everyday lives have completely outgrown their original meanings and we just haven't noticed yet?
That is a very good question to ask.